Good evening, everyone, and welcome to our second online continuing education presentation. Thank you for spending your evening with us. Our first online effort was well attended, and the YouTube version of the event continues to be viewed. Once again, thank you for your support. I think that most of us spent the 1st of January 2020 enjoying a meal with family and looking forward to the new year with both hope and optimism. Little did we know that there was a virus that was lurking in the background that would eventually shatter those aspirations. In my particular case, our daughter was expecting our first grandchild, and our son was to be wed in a destination wedding in Galway, Ireland. While the pandemic could not postpone the arrival of our granddaughter, who happened to arrive just a few hours ago, the restrictions imposed by the pandemic have certainly changed the nature of our celebrations. In the case of our son, well, he has to wait another year. And of course, I was looking forward to our June AGM in New Brunswick, and it was a challenging decision to cancel it. However, in the wake of that, we have seen creativity, teamwork, dedication, and innovation come together to keep our membership informed. I wish to thank all of those who are involved with this presentation, especially Dr. Shahadi and Ellen Holtzman, for the tremendous efforts that they have made in making this effort happen. The frenzy of COVID-19 has brought us some of the best and the worst in both medicine and in politics. Bleach and UV lights undoubtedly is not one of the season highlights. As our country slowly begins to lift these restrictions, we are seeing guidelines that have been created without a lot of discussion, and in many cases, not a lot of logic behind them. Most of these guidelines do not appear to have a mechanism for feedback from the community. They expect us to return to a practice that is either unattainable or unsustainable. This evening's presenters are well known to us. They practice in both academic and private practice sectors, and they bring a wealth of knowledge and experience to the podium. They will review some of the disruptions and the controversies regarding the use of PPE, point of care testing, and environmental controls that have been proposed in the back to practice guidelines. Once again, I would like to reiterate that the views presented are those of the speakers and do not necessarily reflect the views of the CAOMS, or should they be viewed as a standard of care. Please refer to your local public health officers for such direction. I do hope that everyone enjoys this evening's presentation, and as always, please do not hesitate to contact us directly with any thoughts or comments. And as always, stay safe.
So, Kevin, thank you for that excellent introduction. And on behalf of the COMS, I'd be remiss in not congratulating you on becoming a grandfather just a couple of hours ago. And thank you for being here. In spite of that, it's fantastic. So welcome everybody again to our second webinar. The challenge we have before us today is these distinguished speakers that I'll just briefly introduce. We have Graham Cobb from Alberta, who's the section head for dentistry and oral health in the Calgary zone. We have Dr. Nicholas McCool, who's chief of dentistry and oral and maxillofacial surgery at the McGill University Health Center. We have Dr. Sean Edwards, who's director of the residency program at University of Michigan and chief of pediatric craniomaxillofacial surgery at Ann Arbor, Michigan at Mott's Children's Hospital. And last but not least, we have Dr. Brian Rittenberg, who's head of oral and maxillofacial surgery at Mount Sinai Hospital. Gentlemen, thank you so much for taking time out of your busy schedules to be with us and to help us cover the salient points that we are going to discuss. The agenda for tonight, very briefly, will be a chronological discussion of each of the topics. Each of the speakers has approximately 10 minutes to present their short presentation. This will be followed by a question and answer period that'll be moderated by Dr. J.C. Doucette and myself as co-moderator. And you may have noticed in the introductory slides, the email address that's coms.media@gmail.com. You're welcome to submit questions as the presentations go along. These will be addressed at the end of the presentation with hopefully sufficient time to address them. So without further ado, thank you again for joining us. And I'd like to turn the attention over to our first presenter, Dr. Graham Cobb.
Thank you, Tony. Thank you, JC, and thank you, Kevin, for the invitation to be a part of this. I'm just going to flip over to my share screen mode here so that we can see our presentation. And hopefully it'll pop up for everyone. And so, the goal of the presentation is to try to give people a little bit of practical information for returning to practice. By no means am I an IPNC specialist, but being involved in my roles in the hospital and with our clinics, there's been a lot of committee work with respect to inpatient care, ambulatory clinics, non-hospital surgical facilities, and in particularly an upper air digestive tract surgery group in the province that's been trying to review PPE recommendations, and some of which I think will be helpful for OMF surgeons as we return to practice. So I'll jump right into the meat of it here. Are we really, as a profession, at risk? And I think all of the evidence and all of the statistics are pointing to yes, that in particular, our profession is one of those that would be considered high risk. The U.S. Department of Labor, even with some risk calculations based on contact frequencies, the proximity to patients, the procedures that we do, and the frequency of our exposures, that dentists, dental hygienists, dental assistants are very much at risk of contracting COVID-19 through their daily work. We know that in Canada, if you look at the lower left side of the screen, our case numbers are still on the rise. So even though we are doing back to work protocols in provinces, our exposure isn't less than it was a month and a half ago when all of this started. So people need to keep that in mind as well. Early evidence out of China showed that surgeons were particularly at risk. In the early publication in the New England Journal of Medicine, we saw that of the first 23 sort of deaths of physicians, 8 of those were surgeons, and a significant number of them were those with exposures to mucous membranes and surgery in the head and neck region. And then just globally, we know that major numbers of healthcare workers are being affected by the disease on the front line. So I think we need to take our position in this in the pandemic seriously as we take care of ourselves, our families, and our patients. So what is the right level of PPE? So it depends on the scenario. So I broke it out into 3 sections for your office, basically at an intake and administration level. So you have intake staff that are in scrubs, gowns, masks with eye protection, gloves. And those are the people that are sort of outside the office doing COVID screening questionnaires that are produced by your local authorities, as well as doing temperatures before people enter into our facilities. Inside the office, physical distancing is certainly important, just like it is out in the community. So a little sort of restructuring of waiting rooms, as well as the installation of physical barriers between administrative staff and patients, I think, is indicated. Whenever physical distancing can't be maintained in the waiting room or between staff, then certainly level 1 mask protection for administrators in your offices at all times is a reasonable consideration. And then one last sort of little protective equipment change with respect to staff clothing. I think we're going to see a lot less personal clothing at work. Using office scrubs, I think, is indicated with appropriate laundering protocols. If we move into the examination and evaluation, or what we would consider contact level interactions with patients, the step up there is not too different from your intake staff, but again, contact level PE, eye protection for sure, masks, gowns, gloves. I think hair covers in this situation are good to have, but perhaps not mandatory. I think the biggest difference, because you're in more direct contact with patients, there is more stress on the donning and doffing portion of your PPE. So that's why I included in here that, 1, you need to know it. 2, it should be posted inside and outside of your rooms. And 3, your staff certainly need to go through some training with respect to practicing donning and doffing protocols. Pretty much all of the hospital systems have on their websites donning and doffing posters, as well as videos that you can use to reproduce for your staff. As we move into the surgical situation, we're looking at what we would consider AGMP level protection, or aerosol generating medical procedure level protection, all of which you know. So we know that this disease is not an airborne disease, but we know that it is aerosolized by the procedures that we do. Thus, it is temporarily suspended in the air. So the precautions are called airborne precautions, but that does not to be confused with airborne disease. So for this, again, important practice and training of donning and doffing of the right equipment. The N95 masks that we use need to be fit tested to be effective. We know that a double hair cover is indicated, I think, in these situations where your over hair cover can be disposed of after every single scenario. Eye protection, as well as contact water impervious gowns, and you know, even the possibility of double gloving, so that you have the option to remove outer gloves and maintain an inner glove for contact level care. We know that we're going to have some levels of the body that are exposed, and certainly washing the neck in head and neck surgery is probably a consideration, as well as washing your hands during the doffing protocol. Your office should have also in place some protocols for laundering, scrubs, and reusable and protocols for reusable PPE. So for the OMF surgeon, what are these aerosol generating medical procedures? Well, I think we all know for certain, using high-speed handpieces, power instrumentation, reciprocal saws, harmonic scalpels, those are the really you know, sort of known for sure high-risk aerosolization procedures. Then there are probably some that create aerosols, but at a lower radius or a smaller radius, and those would include things like irrigation and suctioning, laser tools and cautery, as well as the patient's reflexes of coughing, spitting, and gagging. So again, the personal protection equipment that we reviewed indicated for, as far as I'm concerned, for all of these things. So just to give people a little visualization, so on the left side of your screen, you know, demonstrated in this is from the Alberta Health Services publication, just a staff member donned in contact level precautions. So mask, eye protection, contact level gown, and gloves with no exposures at the wrist wherever possible. And the eye protection really needs to be wrapping. So they consider eyeglasses not sufficient eye protection. As we go up to aerosol generating medical procedures, I just showed you three photos here of myself. One sort of getting headgear on, the second showing the second level hairnet protection covering the foam part of the face mask, as well as the headlamp, and that's disposed of after every procedure, as well as a full water impervious or resistant gown, and then surgical gloves. Then the picture on the lower right side of your screen is just, as you all know, most of you have all been fit tested, but that is a really important factor in the effectiveness of your respirator. As far as the medical legal concerns go with respect to PPE, I think we just basically need to know that we're either meeting, exceeding the same standards that our hospitals are following with respect to the exposure for aerosol generating medical procedures. And obviously, you know, paying attention to regulations that are coming out from your dental regulator as well. We do have to make provisions for protecting our staff, and we can't have a situation where staff are in different levels of protection with the same level of exposure. So if you're in the operating with an N95 mask, your assistant, your anesthesiologist, whoever's in the room at the same time should be in the same level of protection. And then one other sort of strong consideration is where did your protective equipment come from? I think it probably doesn't matter so much for the gowns and the face shields and the hair protection, but it really matters for your N95 masks. And I would strongly suggest that people make sure that their providers have a medical device establishment license. And then we'll put these up on the website for people to have for resources for after. And I'll just stop sharing there for Dr. Doucette.
Great. So as I mentioned before, there will be time for questions, a question and answer period to follow. We'll move on to our next presenter. Dr. Brian Rittenberg, please go ahead. Thanks.
Thank you, Tony. And thank you to the COMS for asking me to be involved in this very important presentation tonight. And I think the topic that I've been charged with discussing is a nice segue from what Graham discussed, which was sort of PPE in the office, and in particular, how we're going to really protect ourselves from, number one, large droplets. But I think the interesting thing about this virus is that if you look at this high resolution image on the screen here, it'll demonstrate this is a person violently sneezing, which is analogous to an aerosol generating procedure. And you can see that there are two very distinct droplets that have formed from this sneeze. There's the droplets greater than 5 microns in diameter just in front of the person's mouth. We know that those are going to drop to the floor pretty quickly, generally within a radius of about, a meter or so from the patient. And those are the ones that we're going to protect ourselves from with droplet contact precautions. The other droplets that you see here, the droplet nuclei, this sort of fine mist that's filling the rest of this image, those are the ones that are concerning to us. Those are the ones that are probably going to pose practical concerns to us as maxillofacial surgeons, and potentially safety concerns to us, to our staff, and to our patients. Because we do know that this virus can live within those droplet nuclei, and we know that those droplet nuclei will float and remain suspended in air for quite some time after procedures. So how do we deal with that? How, after an aerosol generating procedure is performed, can we return to a room and work on the next patient and remain somewhat efficient? When you look across the country at what the dental regulators are suggesting at this point, then it is still early and it's an evolving subject, but it's varied. So, you have jurisdictions that are suggesting just consideration of alternating rooms between patients is sufficient. You have other jurisdictions that are telling us you need to allow a room to settle for 3 hours following an aerosol generating procedure. And it's very difficult when we see these varying suggestions to know what's real, what's based on some sort of evidence. It will continue to evolve, but what's interesting is there were 2 jurisdictions that actually, I think, are giving us information that is quantifiable. They're providing us with some metric that we can measure to tell us when is it appropriate to enter a room for that next patient. So Quebec and Saskatchewan so far are the 2 jurisdictions, the 2 dental regulators that are looking at a specific metric called air changes per hour, which is something that's very measurable in a room. And we do know that with every 1 air change that occurs in a room per hour, you're replacing approximately 63% of the air in that room. The target is for us to be safe, for our employees to be safe, for our patients to be safe, is to really get to a point where the air in the room is 99%, 99.9, almost 100% replaced with new air that doesn't contain that aerosol that we saw. And so the CDC, this was shortly after SARS, they published this data, which looked at how many with a certain number of air changes per hour taking place, how long would it take to get up to a total of almost 100% of new air entering a room, or all that aerosolized air to be replaced. You can see the targets here, I'll sort of point at them, seem to be this 12 to 15 range. We know that for airborne infection isolation rooms, the CDC has suggested an ACH of 12 be required. Most operating rooms operate at an ACH of 15. And in that ballpark, if we can get there, our room settle time can be dropped from the 3 hours that one jurisdiction in the country is telling us that we have to allow a room to settle, down to somewhere around 30 minutes. So that's really interesting. And that's what's sort of making, I think, maxillofacial surgeons across the country, and I know I'm far from the only one, we're sort of all becoming experts in these areas we're not supposed to be experts in. For example, HVAC and ventilation. And so we're all learning a lot about this ventilation. I know that there's a number of surgeons across the country who are way ahead of this presentation and have already made moves to get their rooms ready. But really there's number one, to look at how do you calculate air changes per hour? Simple calculation. You have to look at the airflow, and I'm sorry I'm using imperial metrics here, but cubic feet per minute. So airflow measured in cubic feet per minute. And you have to know something about your room volume. So if you know those two variables, you can very easily calculate ACH. In a standard HVAC system, a standard ventilation system within a house or an office or a building, this information is readily available. HVAC works on a system of dilution and exhaustion. So fresh air is pumped into a room, dirty air is pumped out of a room. And if you look at this diagram on the left side of the screen, that's a mechanical diagram of one of the operatories from one of my clinics. And you can see the CFM is clearly noted on that diagram as 150. Knowing the volume of that room, a very quick calculation, I calculated my ACH of that room is approximately 8. Well, how do I go from 8 to 15? And initially we did consult an HVAC engineer, and it's a very, very, very expensive proposition if you want to do that with your existing HVAC system. Some people will do it. I can tell you that the province of Ontario, after SARS, considered doing it in all hospitals. There was a mandate to increase the number of negative pressure ventilation rooms. There was a mandate to increase rooms that could be used for airborne isolation. And the Ministry of Health in Ontario commissioned a report which found that the cost to do that in hospitals was too significant to undertake. What they also found was there's an inexpensive way to do it. And that's the way that most of us, many of us across the country have already implemented. And that's using portable air cleaning devices, air cleaning machines. In particular for this virus, for small particles, you want air cleaning devices that are HEPA filters or HEPA filtration devices. And I'm going to talk about CFM again, but I know a lot of us are in this purchase mode now. And the one variable in these devices, if and when you're purchasing them, that you really want to focus on is that variable that I've highlighted, that CFM, that cubic feet per minute. You want to really target that to your room volume. So let's just talk a little bit about HEPA filtration. So HEPA is a designation. It's not a specific or particular type of filter. It's a designation. It's been around, I think it was initially coined in the 1950s or certified in the 1950s. And it's a designation that's assigned to a filter that will filter at approximately 99.97% of particles that are 3 microns or greater in size. So the big question is, well, the COVID virus is far less than 3 microns in size. And we're going to talk about that in a minute. But here's what a HEPA filter actually is. Most filters are a lattice work of these filaments of varying sizes. And they work in one of 3 ways. So for very large particles, those that are far greater than 3 microns in diameter, they'll work by interception. These actual filaments the particles will crash into the filaments. For particles slightly smaller that will be deflected around some of the filaments, they'll be picked up by microfibers on the filaments through something called interception. And then there's diffusion. Diffusion's an interesting one. So if you look at the diagram there, you can see that very small particle. And those are particles that are known as nanoparticles in the range of under 0.1 micron in diameter. They will be affected by something called Brownian motion. Airflow will actually cause these particles, because they're so small, to move in such a rapid zigzag form that in fact we know that more of those particles are actually going to be picked up by HEPA filters in some ways than some of those medium-sized particles. In fact, NASA in 2016 published a report. They were looking at appropriate filtration for spacecraft for the International Space Station. And if you look at the diagram here, what they found was probably the most efficient the particle size that's most efficiently filtered by these HEPA filters is in that range of 0.01 to 0.1 microns in diameter. So the big myth has been busted here, and is that HEPA filters will not efficiently filter particles smaller than 0.3 microns. We know that in fact that they will. So I guess some of the take-home messages that are very important are, I caution all of you, if you're going to go the route of investing in HEPA filters for your offices, it's very easy for us to purchase them and to plunk them down in a room, but you need to understand a little bit about them. The actual efficiency of these filters is going to be determined by a number of factors. Number one, the airflow rate. So yes, these will have a certified CFM when you get them, whatever it is. And the day you get them, when the filter's clean, that's in fact what those machines will be doing. But as these filters start to accumulate particulate, the airflow is going to drop through them. It's interesting because the filter itself will start filtering better, but it won't filter air as quickly. So that's one consideration. Number two is room placement. Where in the room are you going to place that filter? There are some areas within a room that are far more ideal based on airflow than others. The third is you need to maintain these devices. They need to be properly upkept. You need to change filters at appropriate times. And there are a number of other variables. And so we do know that a rating, for example, a CFM rating of 400 is probably not going to be 400 in real life. And in fact, in the report that was commissioned by the Ministry of Health in Ontario, they do talk about multiplying a factor of 1.5 by whatever base CFM you've calculated that you need for your room. And that's actually what you should be targeting. Best way to do it is if you figure for your room, you need a CFM of 400 to achieve 13 ACH. You probably should really be looking at a machine that will have a CFM rating of 1.5 times that to achieve that. Just in closing, the only thing that I would recommend is, although again it's very easy to buy these filtration devices and put them in a room, and it's probably the least expensive way to achieve what we think our regulators are going to use as a metric to allow us to settle rooms more quickly. I do think it's still worth a small investment of engaging either an HVAC engineer, an HVAC consultant, someone who can come into your space, assess the ambient ACH, assess the airflow, tell you the best location within a room to put these machines, and probably most importantly, certify or give you some documentation as to what you've got there and what equivalent ACH it's generating. And in fact, the last thing I'll tell you is that that document that was commissioned post-SARS in Ontario makes this very suggestion. And on that note, I think that's my very quick review on ventilation considerations for COVID-19.
Great. So thank you very much, Brian, for excellent, and thank you for that succinct presentation. I'm sure we'll come back to some questions that people will have on that. Our next speaker is Dr. Nicholas McCool, who's going to talk about ramping up activities in an academic hospital and surgical practice in a program that's very near and dear to my heart at the McGill University Health Center. Dr. McCool, if you will, please.
Thank you very much, Tony, and thanks to the whole COMS committee for asking me to share a bit of our experience of what's going on in our academic programs, as well as to maybe give a little bit of insight to all of our members about the staging and ramping up of hospital surgical services, something that affects all of us as oral and maxillofacial surgeons. There's absolutely no doubt that academic programs look a lot different now after about 7 weeks now within this pandemic here in Canada. We've had to do some massive restructuring of our residency training programs, mostly to assure the wellness and safety of our residents. Some of these things include having a skeleton crew on at the hospital, so only 2 residents on at one time, so that if there is any type of exposure within the department or the operating room, only a few residents will be affected. Also things like sending only the senior resident down to the emergency room to analyze or to evaluate a patient rather. This way, you not only save on PPE when you have a junior having to go to report to a senior who reports to an attending, they'll also be able to execute out their treatment right away in the emergency room. There's been a lot of changes, but there's also a lot of opportunities for our residents to learn from this pandemic. I mean, things within leadership, administrative skills, crisis management, how they're going to ration our PPE supplies in the department and the use of different PPEs in order to keep them safe. I think our residents all think they have an expertise in aerosol generating procedures now, something that they probably wouldn't have had this pandemic not occurred. And it's also the leadership that they've developed and having them on as frontline healthcare workers and the face of oral and maxillofacial surgery in our hospitals and in our emergency rooms are largely our great residents. We have restructured surgical learning or didactic learning. I'm sure every program director, surgical, medical, dental, across the globe has instituted virtual meetings and digital platforms to be able to teach. At McGill, our residency program director, Geneviève Chasson, has done a great job of keeping all of our rounds, our ground rounds in place through medias like Zoom. You also have these excellent collaborative interinstitutional didactic programs named COVID, which is institutions of oral maxillofacial surgery across North America, teaching residents with staff from different programs. It's almost like having a mini symposium 2 or 3 times a week and hearing from excellent speakers, like I said, across North America. It's also important for us to remember that we have to adapt our current educational standards. Things have changed. Medical, surgical, and dental specialty licensing examinations have largely been canceled for this spring and been moved to somewhere in the fall. It's important to remember, this could be devastating to your residents or devastating to a resident. If you think back when you were a senior resident, you want to finish your year, you want to study hard, take that examination and finish and start a whole new chapter of your life wherever you're going to practice. And now our residents are sort of in this gray zone, just waiting to, when they're going to take their exam, how they're going to take it, what media will it be online, etc. And we have to make sure that our dental regulators are cognizant of this. Provinces should be aware and be sensitive to the fact that our residents will need temporary licensure until they can take their certifying examinations and be able to practice as specialists in the meantime while we're trying to figure everything out. And this too will bring a new surgical norm, just like going to the grocery store will be different in a year, maybe 2, maybe longer. I think residency is going to be a little bit different after this. We've learned a lot and we're still learning a lot, taking care of our residents, again, wellness and safety. These excellent collaborative platforms that I think that are absolutely outstanding and should continue well into the future. It brings together people from different programs, residents from different programs, and sharing of ideas. The innovation that residents have had, 3D printing face shields and also 3D printing face masks and these sorts of things are really excellent additions to our program, although, of course, there are negatives. And those negatives largely come from, we're surgeons, we love to operate, that's why we do what we do, the decrease in elective surgery that we're all experiencing. Here in Quebec, as of March 13th, the province had stopped all elective surgery, which means that the vast majority of the operations that we do and we train our residents in had stopped. The interesting thing is that the American College of Surgeons has issued a statement saying that The first wave of testing our healthcare systems was really the first wave of the pandemic. And the second wave of testing our healthcare systems will be catching up with all this pent-up patient demand for surgical needs, and OR time and resources and etc. And therefore, obviously, this will be a gradual return. And this gradual return will be predicated on several things. First, of course, the famous curve that you can't watch an hour of TV without seeing these days, flattening that curve. Most provincial jurisdictions are wanting to see a 14-day consecutive decrease in the amount of new cases added of COVID-19 before easing restrictions to open up elective OR time. Testing is a huge thing, and you'll hear from Sean afterwards, probably a lot more about testing. But in the operating room, and for us to go to the operating room and feel safe that we're operating on a patient, particularly if it's elective surgery, we want to know that that patient does not have COVID-19. I can tell you that we had gone through many different scenarios in our hospital system where we went from no testing of asymptomatic patients to testing only asymptomatic patients who are having a aerosol generating procedure, to very, very recently testing all asymptomatic patients undergoing surgery. And within that very short time, we found patients that have come in asymptomatic, no risk factors, and tested positive. Well, of course, they're having a surgery that can be deferred, and that surgery would be deferred for the safety of not only the staff, but also the patient. We also know from a few reports out of Italy and Wuhan, China, that taking patients that are asymptomatic and have the virus or are carrying the virus and putting them through a stress of anesthesia as well as a major operation can also increase significantly the morbidity and the mortality to those patients after a procedure. Therefore, it's very, very important, again, to be able to have the resources to test our patients, and all of us in the hospitals should be really on the front lines asking to make sure that patients are tested before having procedures. PPE, of course, as you heard from Graham, this is a huge, huge issue, probably in any hospital system. Not only is it a big issue right now, but will continue to be an issue going forward as governments and jurisdictions try to stockpile adequate PPE, not only to keep up with opening up the operating rooms and hospitals, but also for that potential second wave of COVID and maybe a third wave of COVID that we'll experience. As economies start to open up and people start mingling again, for sure the increase in the community spread of the virus will have an effect on the amount of patients that will be coming back and filling our hospitals. And finally, looking at something like prioritization and scheduling. And this will be probably one of the biggest issues for oral and maxillofacial surgeons in the short to medium term as we try to get our patients back into the operating room to have the necessary care that they deserve. And as I mentioned, it's going to be a gradual recovery. So that means that looking at things like beds, ICUs, ventilators, I mentioned PPEs, medications. I mean, there are several weeks here where there's a lack of propofol or any other anesthetic drug. Therefore, we have to reduce the volume in the operating rooms. The government directives, of course, will be on ramping up slowly. Here in Quebec, again, we're operating at about 30% of OR capacity. The next phase will be to go from 30 to 70%, and finally up to 70% and above. And this is projected to take months, if not, in the order or magnitude of up to a year or maybe more. And therefore, it's important for hospitals to use things such as committees that have surgical leadership, anesthesia, OR staff leadership, and ethics members to look at OR waiting schedules, to see what cases are being booked, how they're being booked, who's waiting and who's not. And Therefore, for us as surgeons, we'll have to take a good hard look at our list and start thinking about what needs to go to the OR quicker. I mean, some are easy questions, benign versus malignant disease. Then you have patients that need TMJ replacement. You know, are they symptomatic? Are they non-symptomatic? Is it causing a much decrease in their ability to function? Looking at patients that are being canceled several times and waiting surgery and putting their lives on hold to have surgery, and then finally getting canceled over and over, as well as those that have just been waiting a very, very long time. So as we go forward in these next few months, like I said, if not longer, we're going to be hearing a lot of terms like, this is emergency surgery, this is urgent surgery. It's very important for us as oral and maxillofacial surgeons to realize that, our surgeries are important and they're crucial, not only to our patients, but in academic centers as well, where we have the commitment to training the future generations of surgeons. And therefore, we need to have strong leadership, particularly on these committees in the hospital, to make sure that we're well represented so that we can make sure that we are able to achieve all of our goals of patient care and education. And with that, I want to thank you again. I'll end the slideshow here.
Great. Thanks, Nick, for that very interesting presentation. Without further delay, I'd like to turn things over to Dr. Sean Edwards, who's going to speak to us on the topic of point of care testing. Obviously, a subject that will have hopefully significant ramifications on our practice patterns and our risk exposure. Thank you, Dr. Edwards.
Thank you very much, Tony, and I really appreciate the opportunity to be here very much. So my task is to speak on the state of testing, and point of care testing is going to be one part of this. When it comes to COVID, I think there's an awful lot that you hear in the news these days about the different types of testing. There's a lot of demand for testing and a lot of confusion about it. So in an effort to try and find some of the confusion, I want to kind of highlight. So we basically have 3 tests that we can use for COVID, or really for that matter, for most viral work and viral research. The first one, which I'll dispense with right away, is viral culture. That is not something that we're using clinically. Viral culture is a way for us to determine if viral particles are viable. It's really something that's been done in very small centers in research settings, and it's not going to be something that's practical for us at all in clinical use. There are some good takeaways from this. Viral culture patients have informed CDC guidelines for when people can go back to work, or from when they can leave the hospital, or when they're no longer considered contagious. And a couple of the small studies have shown that 8 days from symptom onset, the patients are no longer showing virus that you could culture. And so for that reason, the CDC has some guidelines, which we could talk about later, about when you can resume activities, assuming that 8 days from symptom onset, you are no longer contagious, as long as you effervesce and you're no longer short of, and as one symptom-based return to work kind of protocol. The 2 other tests that are out there are broadly classified as viral or serology tests. Viral test is a test which is done with collecting some kind of body fluid, and we're going to look for presence of viral parts. And those viral parts are going to be nucleic acid antigens. These are the only diagnostics that we have. The serology tests, they're looking for patient's response to an infection. So we're looking for their evidence in that patient that they've developed an immune response to the infection. And there's an awful lot of variability, which I'll come in a second. So the viral tests out there now, the vast majority of them are based on nasopharyngeal swabs. So a long Q-tip introduced through the nasal cavity all the way to sent to your adenoid. And then PCR is done on it. So reverse transcriptase PCR test is done. And that's mostly looking for nucleic acids. So nucleic acids don't equal viable viral particles, which is an important thing for us to keep in mind. These viral tags, there's a lot of concern, because we all know there are 7 coronaviruses that are known to affect humans. And so the markers that have been chosen to be amplified are specific to COVID-2. There's several targets, because we don't want to run a test that may detect the presence of an innocuous form of coronavirus, one that maybe gives you just a common cold. And so the RNA targets right now, this is an RNA virus, have looked at envelope genes, nucleocapsid, the spike protein, RNA ribosome protein, that's the RDP, and ORF1. And all of them will be very active. There's been an awful lot of improvement in these tests. And so early on, if you read any papers on the accuracy, the sensitivity, the specificity of these tests, a lot of them are showing wide ranges of sensitivity and specificity, and many of them very poor. And so they felt in an effort to avoid false negatives and false positives, you would have to test multiple sites. Those recommendations have since changed. So with validated and approved tests, PCR tests, you no longer do, and testing for one of these markers is adequate and adequately sensitive and specific. The one exception being the one marker that you see there, the SARS-R from Charit, and that one, because of some reagent problems, is not shown to be sensitive. Now, so these PCR tests are going to amplify RNA. So they take bits of nucleic acid from stool, urine, semen, gastric contents, the lower airways, the trachea, the pharynx, the oral cavity, the nose, the tears, and they're going to amplify any nucleic acid that's there. So the speed that happens, the number of cycles of a PCR machine takes to do that, depends on how much nucleic acid you can collect. And so, what you'll see down here on the bottom left-hand part of this, that tells you the number of cycles it takes to have fluorescence to detect the presence of these RNA markers, meaning we've amplified the right nucleic acid. So the more positive somebody is, the more RNA that's there, the faster this is going to happen, the fewer cycles it takes. So if you can get fluorescence with less than 40 cycles, that's considered to be positive. And it seems to be that people are more severely infected, have a higher viral load, and so are able to amplify that DNA, or the RNA rather, with fewer cycles. So I want you to understand is that this is the only diagnostic test that we have. This is the only way to tell if somebody who's manifesting the symptoms of SARS-CoV-2, this is the only way we can actually diagnose it. This is also the only test that's being formally evaluated by the FDA in the US. And so serology tests, those looking for evidence of the host immune response, are not really being overseen by the FDA. There's at least, I looked on the website today, at least 179 different people and sites that have developed tests that have applied for emergency use approval, which the FDA is only sort of dipping its toes into, and is not really doing a whole lot to validate them. As a result of that, these tests have a huge variability in their accuracy. A survey, my own survey of these, you'll find negative and positive predictive values of these tests at about a 5% disease prevalence to range from as low as 40 to 50%. And so it has, if you are going to do anything with these serology tests, there really has to be a lot of internal vetting to verify their accuracy. And you can't just rely on what is provided by the companies making these tests. So now, what is the significance of these tests? Well, serology, as I'll show you in a second, is not going to be useful for us as a diagnostic test. It may, however, be a very useful test for us to survey the population or define populations for the prevalence of the disease. And that will have some important consequences for us as we move forward. It may also help us understand how contagious this disease is. And with further testing, it may, we don't know yet, it may correlate with a level of immunity. And as of right now, we do not know that the presence of antibodies in your serum are any guarantee of immunity to this virus. We don't know the antibodies, which antibodies we should be targeting. We don't know if the presence of certain antibodies are going to have for higher levels of immunity. For instance, the nucleocapsid proteins are where most of these antibodies that we're testing for, they're actually not specific to the viral binding. The RBDS, which attaches to the spike protein is more specific to the coronavirus attachment, but there's some concerns that even though it may be a better indicator of immunity, it may also have a higher cross-reactivity with other coronaviruses. We're not really sure what to think of that in terms of significance. The one thing that may come from this, the one concrete fact that may come from this quickly, is that this may allow us to identify people who can donate convalescent plasma for treating the severely ill patients with COVID disease. So the testing for this is very much unlike SARS or MERS. And the problem for this, and there's a lot of hypotheses about why this disease spread so well compared to SARS and MERS especially. And some of those thoughts relate to the fact that this may be more contagious than these other viruses, that it is more prone to spreading through aerosols, unlike an influenza, which requires larger droplets for transmission. But it also seems in some recent data, particularly coming out of the nursing homes in Washington State, that viral loads are peaking prior to symptom onset. So if you look at this chart I have up here, the gray part on the left is prior to symptom onset. The brownish orangey stuff on the right is after symptom onset. So if you look at the curves, the blue curve here, this is viral RNA that would be detected prior to symptom onset. And so what you see for a week prior to the onset of symptoms, there is a significant increase in the viral load in the nasal cavity, which means that, and this is what's been into the past concerns about the contagiousness of asymptomatic, if we are relying on things like fevers and coughs and symptoms, these patients are spreading viral RNA prior to the onset of those symptoms and for at least a week prior. The viral load stays high for at least a week, but there's a tremendous amount of variability in that. And there's also a tremendous amount of variability in the viral loads of different body substances. So for instance, there's very low viral loads in urine, but there are higher viral loads in stool. So oral spread is definitely a mechanism that this can spread. The nasopharyngeal swabs have very high loads. Bronchoalveolar, so fluid from lower airways, has the highest viral load. And so how we detect this is going to matter a lot. If we want to make testing something that's very easy to use in an office and not intimidating to patients, well, it would seem that the oral swabs are going to be the easiest, but oral samples so far don't seem to have the same levels of nucleic acid that nasopharyngeal swabs, airway samples do. The second thing I want you to notice here is that where the viral RNA drops off is quite a bit different. So this blue curve nasopharyngeal swab is really starting to fall off for most patients at 2 weeks and even up to 3 to 4 weeks, with some patients shedding virus for more than 6 weeks after infection. If you look at this yellow curve, this is the stool. And so what this is that in most studies have looked at testing patients is that viral particles are being shed in the stool for a longer period of time, which means that even when patients seem to be convalescent, the fecal oral spread may still be a mechanism for spread of this disease. We have an awful lot to learn about how this disease spreads, and the only way we're going to get there is with massive increases in our access to testing. This is probably why we got caught the way we did, why the disease was able to spread so far and so quickly. It was the general lack of testing everywhere, in North America, in the US especially. And so we are rapidly adapting to our testing capacity. At Michigan, what are we doing? Our current strategy and our goal is to test all pre-op patients within 96 hours of their operation, including with a screen for signs and symptoms of COVID and sick contacts. And so if you have no signs or symptoms, you have no sick contacts, and you've had a negative test, you'll be able to have your procedure done in the operating room, exactly like Nick had alluded to. But we're also going to apply this to our ambulatory clinics. There's a lot of reasons for that. It's going to decrease our resource utilization. It's going to decrease our PPE burn rate. It's going to completely change our patient flow, our ability to not wait for those room clearance times like Brian was talking about if we have patients with negative tests. And so we're moving very aggressively to test ambulatory patients in our clinics, not just in the operating room. The second part of this, which I think is very salient, is patient confidence. And trying to bring patients back into dental offices to have regular dental care, to have elective procedures done, is going to require patients feeling safe. And the ability to test patients routinely and show that they're safe, and for patients to know that everybody being treated in an environment is COVID negative, will do an awful lot to increase patient confidence and their willingness to undergo elective procedures in the ambulatory care setting, which is especially important for oral surgeons in so many things like wisdom teeth and dental implant placement. They're going to need that. The downsides are significant though, and the downsides relate to our ability to ramp up this testing capacity and the logistics of getting this done quickly. As of right now, when we're doing this testing at the University of Michigan and most places, these tests need to be conducted at least the day before, because the turnaround time for accurate testing is not a matter of hours, or a matter of minutes rather, it's a matter of hours, and on the order of 6 to 24 hours, particularly for high throughput testing. So this leads to a lot of questions, and as our economy tries to ramp up, testing is really going to be the key. There's an awful lot of challenges in doing that, and it's not just having enough people to do it, it's having the reagents, it's having validated tests, and it is a virtual Wild West right now in the private industry developing these tests. We are not going to be able to do proper source tracing, and we're not going to be able to monitor for flare-ups if we don't have routine random tracing. So it's not just a matter of testing everybody once. It's being able to test repeatedly and randomly to identify flare-ups so they can be shut down quickly as we resume, as we try and resume normal and some form of normalcy. How we scale up testing is one of the things that I've been telling anybody who will listen nationally and locally at state levels, and that I strongly feel that dentistry needs to be involved in this increase in testing capacity. At the federal level in the United States, there's a lot of discussion in using pharmacies to conduct this testing, and I think that the dental community is actually far better suited to do that. Our offices are already prepared and adapted to proper infection control. We want to marshal the PPE resources where we can, and dentists are already familiar with the anatomy in this area, and I feel that dentists are far better and are far more reliable source of this testing capacity than would be pharmacies. Imagine going into a Shoppers Drug Mart to get your nose swabbed, and you're standing next to the mascara, the toothbrushes, and the Dr. Scholl's foot gels. It's just not that's just not going to be a practical response. Whereas a dentist's office, particularly where dentists I think will have extra bandwidth, they're just not going to be as busy with their regular procedures, will be able to do that testing and have a mechanism in place for reporting it to local public health sites so that positive tests can be followed up, source traced, and isolated to prevent large-scale spread. Other questions that remain, though, are testing of asymptomatic patients. Older patients and younger patients have different presentations and trends in terms of how they shed nucleic acid when they develop antibodies. Patients that seem to get very sick seem to have lower levels of antibodies than do those who have mounted an effective immune response. We don't know what to do with immune-compromised patients. We don't know how to use any testing for them. We don't know which targets to test, which ones are going to confer the highest level of immunity. So we need a tremendous amount of testing and research quickly to be able to give us these answers to have any hope of resuming how we do that. And then finally, point of care, I think, is probably going to be one of the best ways to do that, meaning that a test could be done in an office, a clinical site, a temporary health center, and then the testing completed there instead of packaging up that sample and then mailing it to some site. One of the things that we're going to need to do to be able to stay ahead of this disease, because we have this period of asymptomatic spreading, is we need very rapid responses. And if we're going to rely on mailing specimens to some central lab in some province, in Toronto, for instance, or Montreal, or Halifax, that's just not going to give us the answers fast enough to be able to shut these things down. And so we're really going to need to rely on point of care testing. To date, point of care testing has been the Achilles heel, and that the accuracy is not good enough, but I'm certain this will be a short-lived thing as this all gets solved. The FDA has put in some commitment in the United States to home testing, but home testing, you can imagine the morass that would be, that you will have Joe Johnson and Susie doing this test themselves and trying to run it. It's just not going to be practical. It's the FDA is committed to having home tests done and then samples sent to central labs. But I think that the same problems exist with that in terms of the rapidity of turnaround the results. Finally, as we ramp these things up, we're going to continue to need to allocate our resources appropriately to the places where it's needed most. And that'll need a lot of smart people while we ramp this up, because we've got many months of this ahead of us, not days. And with that, thank you very much for your time.
Great. So, gentlemen, congratulations. It's always a challenge when you're confronted with a 10-minute TED Talk type of time limit to transmit this kind of information, and you guys did fantastically well. I'd just like to say, before we move on to the question and answer period, that on behalf of the COMS executive, we're extremely proud to have this distinguished panel of academic, community, private practice leaders from various geographic jurisdictions share their knowledge with us. And I think this is just one of the representations of the benefits of an affiliation for potential members with the Canadian Association of Oral Surgeons. So guys, thank you so much for your time. I can tell that there's a lot of questions brewing up from those that are being emailed in. We're going to move on now. I'll pass things over to Dr. JC Doucette, who's going to carry on with some question and answers for each of the speakers. If we can proceed to that, please.
Hi, everybody. So again, thanks to all the speaker for the great presentation. I'm going to start by asking a question to Dr. Cobb. So obviously, it was very informative to understand what type of PPE we're going to need, but many of us also understand that there's going to be a huge supply-demand issue once we ramp things back up. So in your mind, how do you think we can mitigate this supply-demand issue? And in that mindset, is there a role to move towards reusable PPE?
So good question, JC. I think I'll start it with the reusable PPE. I think reusable PPE is one, it's very easy, I think, in the gowns department, like the clothing department, scrubs, face shield department. That's all relatively straightforward. The virus is sticky and very contagious, but very easily killed, which is helpful. So there's lots of cleaning protocols out there with respect to, it's pretty easy for you to find out what you clean plastic face shields with, et cetera, so that you can reuse them. I think the harder thing is the N95 mask issue with respect to the reusability of, and establishing clean and defined protocols. One, for how to sterilize them, and then secondly, like how frequently could they be sterilized before they're degraded and lose their quality or their effectiveness. I think it's going to be a balance between when supply chains catch up on the manufacturing side to make them available, or when things like point of care testing, if that availability sort of supersedes the need for such a large demand. So as all of these things get sort of ramped forward, it'll be kind of a bit of a race to see which product comes to market more quickly. That'll kind of solve some of those issues for us. I don't know. I hope that answers the question, but.
Yeah, and talking about PPE, the other thing we might have not think about is gowns. Prior to COVID, did you use gowns for third molar extractions in your office?
Yeah, good question. So we did use gowns regularly. We did have a couple of options though in our office. We did have some that were more like butcher style gowns that didn't have full arm coverage, but we did have reusable water impermeable gowns, and we did have disposable gowns that we were using for all implants, bone grafts, like every single sterile surgery case, we were using full gown coverage. Some docs used the reusable gowns or the full gowns still for third molars, and some clinical staff did as well. But it wasn't for tooth extractions only. It wasn't consistent, and I think it will be consistent.
Okay, thank you. In interest of time, I'm going to move to some question to Dr. Rittenberg. Thanks again for the very informative presentation on ventilation. But let's say you started over and you had to rebuild a new office. How would you change what you have made compared to your existing one?
Yeah, it's a good question. I think the one thing that I'll preface the answer with is it depends whether or not you own your location or you're leasing your office within a building. Because the concept of cranking up CFM within an existing HVAC system, which would really involve really blowing or exhausting air at a high volume to the outside environment, and bringing fresh air into them, it can be done. But if you're leasing space, which probably most of us are within a building, you're essentially blowing out heated or cooled air, depending on the season, and bringing the opposite air into the room. So I think it's probably not realistic to be able to to do that within a leased environment. If you own your property, you can do it. But I think the expense, I think, look, if I was building an office now, the short answer to your question, and I owned the space, I would have a highly efficient HVAC system that would crank out 15 ACH with HEPA filtration. But I don't know how realistic it is in the current environment. And I think what we know about these portable units is it can be done efficiently and relatively inexpensively.
And talking about those portable units, those mobile HEPA filters, do you know if they affect your HVAC air exchange per hour?
So you can actually calculate it. So it's a simple calculation. And I'm happy we can actually put my talk on. I have another document, Tony, that I'm happy to share. It's a real easy calculation to do based on the CFM of the unit and taking in that sort of efficiency or lack of efficiency factor. You can calculate what CFM you want to target with these machines. But again, the location of the machine, I think, is critical. The upkeep of the machine is critical. And some things I'll tell you about, when you're buying these machines, there's going to be UV light options and other options that'll be kind of added expenses. The concept of UV light options within these machines, UV light will kill this virus at the right wavelength, but it's not UV light alone. It's UV light plus the time that the UV light's in contact with the virus. And when you're running one of these machines at high CFM, the virus simply is not going to be sitting in front of that UV light long enough to degrade it. So they're nice. They're nice for other maybe germs and contaminants. But if you're looking to save a bit of money, they're probably not required on these machines. The HEPA filter in and of itself should do it.
Thank you.
Hope that answers your questions.
No, that's great. The other thing we often hear about is, the negative pressure rooms to minimize the spread of the virus. But actually, in an oral maxillofacial surgery practice, can you discuss, the pros and cons of building negative pressure rooms?
So I think, I don't know, and others that are far smarter than me could maybe talk to the value of it. I think it depends on what you're doing. Number one, it can be done. You can actually convert a room. You don't, and in that document that I referenced, the Ministry of Health document here, they stipulate you don't necessarily need an empty room to create a negative pressure room. It's very expensive to do. And I don't know that the yield, I think when our goal with this particular virus is to eliminate that aerosol from a room, it can be done with high ACH that doesn't necessarily give you a true negative pressure. But if anyone wants to spend a lot of money, I know from our HVAC engineer we've engaged, it certainly can be done. I think, we're not building airborne infection isolation rooms in our practices. So I don't know that there's value there for it. Maybe there is for other reasons, but with this specific virus, I don't know that there's value for it.
Great. Thanks, Brian.
You're welcome.
I'll move on to Dr. McCool. So thanks for your great presentation, your perspective on the academic and hospital practice. So in your hospital, when are they planning to restart non-urgent surgery?
As I sort of mentioned, it's a work in progress. Right now, there are far too many cases to start opening up or expanding into elective surgery. What the ministry is looking at, as well as the leadership at the hospital, is first that flattening of the curve. The other obstacle that we're running into, particularly in Quebec, is a major lack of beds. So a lot of our COVID patients that are recovering come from long-term care facilities. And those long-term care facilities, if you watch the news anywhere in Canada, you'll see that they're a huge problem, particularly in Quebec. So they can't go back to those long-term care facilities, even if they're past sort of the acute pulmonary phase of their infection. and so they're sitting a lot in our hospitals. The government has made, makeshift hospitals and converted centers for places to take those patients. Then we run into, you find a solution for that, and then there's another problem, which is staffing them. When a lot of these long-term care facilities, they had infected healthcare workers, so they're essentially out of commission to be able to staff them. And so it's really a difficult problem right now until we liberate the resources within the hospital. I think that, certainly the next steps will be to slowly increase the amount of operating room time. When we do that, we will obviously be competing for operating room time with those that have had, more urgent cases that have been waiting. So it's going to be a long, gradual process, I believe, and something that will take the magnitude of several months.
Thanks. And talking about competing, how are you going to be able to advocate for your patients? When we talk about orthognathic and TMJ surgery, most of us know that it's elective in many cases. How are we going to be able to get them done, and when is this going to happen? Obviously, it's going to depend on the region you're practicing, but what are you saying to hopefully get those surgery done at some point?
I think I think that the way that certainly I hope that we continue looking at this problem in our hospital system, and hopefully others, is that as the percentage of operating room time increases, that time will be split into emergent time, urgent time, so for urgent cases, and then what's left over, say if you're operating at 60%, you save 20 or 30% of that as block elective time. As I was trying to get to in my presentation, I think it's important that we remember, people that have been waiting for 8 months for an elective procedure, that becomes, up there on the list, and therefore you have to consider that. And as block elective time starts getting liberated to our divisions, mixed plastics, whatever, and OMFS, we will start getting a piece of that elective time, and we will have to start within our own divisions, categorizing and prioritizing patients to go ahead and have elective surgery. And those would be, again, based on our definition of urgencies, which would not be in competition with, the definition of urgency in, say, GI surgery.
Thank you, Nick. Now I'll ask Dr. Edwards some questions. Thanks again for the great presentation. So I think one of the answers will come out of point of care testing, and it's very interesting. But practically, how are we going to be able to incorporate point of care testing into a busy, high patient volume OMF practice, especially, for example, a private practice?
Yeah, it's a great question, JC. And, I think there's going to be a few things that has to happen. So in the States right now, there is limitations on who can bill for this, but there are codes that have already been generated for this type of testing so that you can capture revenue. Right now, the dental school has started this kind of testing. The University of Michigan School of Dentistry has, and the amount of revenue they're capturing per test doesn't really even cover the cost. So that'll have to change. And I think in the absence of that, and particularly in the more of the Canadian healthcare system, I think there's going to have to be a massive public investment in this to take care of this kind of testing, to ramp up this level of testing. I don't think it's going to. I can't imagine that it would be practical for us to put this in every dental office, but it may be that every oral surgeon's office in every community is going to provide this testing for patients and so on. And I think that some of that testing capacity could come from dental offices, the way that the federal government in the U.S. was envisioning pharmacies doing it, and that the pharmacies are going to provide that access so that other things can happen. Workers can go to factories, grocery store workers can work in grocery stores, And, you know, there's a whole ethical thing that gets around immunity passports, and I don't think we should be talking about that either. But we just need to have broad access to testing to be able to, you know, to be able to function. I'll add one more point to the importance of that, JC, is that, you know, we were in some ways fortunate that the COVID hit North America after the bulk of our flu season was done. Imagine now we get in September, October, and we hit a coincident wave of resurgence, I guess, of coronavirus, along with the standard flu season. We'll have all these patients coming into us now who have a cough and a nose like they would in any ordinary flu season, and this was projected to be worse. And you have no idea what to do with them. We have flu tests, we have flu vaccines, but if we're not able to massively ramp up our capacity to do COVID testing, then you're going to burn PPE and all those people, and we're going to be frozen because the number of, you know, our economy will be frozen, our clinical care will be frozen. And if there is a time threshold on this, you know, we really need to get this in place before the next flu season hits.
And realistically, and you might not have the answer, but how far do you think we are from actual point of care testing?
So that's a great question. So there are, so there's a bunch of moves in that direction. We already have some point of care testing. We have point of care testing for both serology and for COVID testing. The COVID testing is what we need for the actual diagnosis, but the serology will be really helpful for us to understand the prevalence of disease. So for instance, if you are in a very rural part of the country, and as we've seen in Canada, it's done relatively well. You know, there may be things you can do with that economy, the healthcare system, that make it efficient and more cost effective if you have an understanding how prevalent the disease is. There are at least 2 point of care COVID test machines available, and Abbott is one of them. That was the first in the media and the most famous. It still has problems with sensitivity, but that will improve. The NIH in the US has funded kind of a Manhattan project now for rapid development of this kind of COVID testing. The hardware is pretty fast. I mean, they're mostly working with PCR machines, and so it's a matter of simplifying the reagents and so on to make this happen fast. They emergency use approval was provided to a group out of Harvard, I guess a couple days ago, for what they call a single pot test. They're using a CRISPR strategy to develop nucleic acid amplification tests, and so essentially they're using CRISPR to look for a key sequence and inserting a fluorescent molecule into it so that it highlights it. That's a single pot test that is quick, easy. It's made in a little rubber mold, and so and because it's only one reagent, it's a faster, simpler test to roll out. So, you know, it could just be a month or so before we start to see more of this, but I think realistically we're going to have to work awfully hard through the summer to get ready for the fall.
Thanks, Sean.
We do lack leadership I'll say one other thing, in the States, the ADA is not taking, from what I'm told, they're not taking, I have not had direct conversation with the American Dental Association, but I really do think we need some strong leadership in this area so that we can take advantage of our dental workforce, and probably not all dentists, but certainly, you know, maybe we're all oral surgeons, to be able to provide this testing for our community so that we can, you know, have a better understanding of what's going on. Sorry.
Thanks, Sean. And thanks again to all the speakers for answering my question. Maybe now we'll move on to question from the audience.
Sure. So, Dr. McCann, I'm sure you've had an opportunity to see the quantity of questions that have been coming in from the significant number of people who are watching us online. Can I ask you to please share some of those questions with us, and particularly with our panelists? While we're waiting, there was one question that came up for Dr. McCool specifically, just out of curiosity, Nick, in terms of the reception of the institution towards, you know, the expression of needs for PPE equipment for oral surgery and dental procedures. Did you find a fair degree of reception and recognition of the risks that we were exposed to in our profession?
I think it took, it's a great question. It took a lot of discussion. At first, you may have noticed, Tony, working at the same hospital, that the list of AGMP procedures did not include us and the procedures that we do. It took, you know, a couple of phone calls, emails, Zoom meetings to get are procedures on there, and then they slowly drift off, and then you have to sort of repeat. But I have to say that, you know, the people are very receptive. I mean, the data and the literature is out there, and it makes common sense. And our AGP procedures have been treated just like an ENT, AGP, or AGMP procedure as anyone else, which means that the proper PPE would be issued to a person who is doing high-risk surgery. It just, as always, in our hospitals, takes a little bit of education of our medical colleagues.
Right. You know, one of the questions, and this is something, one of the recurring questions on the subject that comes up, is there's two camps in the context, two general camps, and these are generalizations. They're not always valid, but there are two camps in the approach to this scenario. One of them is perhaps I hate to use the term, the alarmist or extremely conservative camp that's very concerned about airborne transmission. And the second camp that I encounter is, there's a bit of a dichotomy there, is the camp that looks at saying, you know, we've been confronted as a profession with aerosol our entire careers. We've been confronted with many viruses that have been aerosolized by the procedures that we do. So why is this any different? Why is this any different than HIV, hepatitis, influenza that's been aerosolized? Are we at greater risk with COVID-19 in its aerosolization? Not necessarily to you, Nick, but if you want to answer it, then great.
I mean, I can start. I'm sure everybody can give their opinion because you know, they're opinions. I don't know. I don't think anybody knows the exact answer to your question and which way, you know, the pendulum should swing in terms of PPE and safety with aerosols and this novel virus. I think it comes down to taking the limited evidence that you have. And I can speak particularly, you know, for myself and being in a residency training program and working with residents and trainees in particular, that when you take the evidence that you have to err on either the side of caution, or you err on the side of, you know, where your comfort is and your beliefs are. And I think for us, you know, we have to err on the side of caution until there's further evidence and data to suggest otherwise. For me, again, knowing what I know in my personal opinion, that's where, you know, my opinion lies, I guess.
Okay. Thank you, Nick. Thanks a lot. So
Tony,
I think,
can
is Kevin?
maybe make a quick comment?
Of course, please.
Yeah, I just think that what you mentioned about the virus, I've seen that question a lot too. But the viruses are not the same, right? They're not all the same. They're not transmitted the same. You know, we get hepatitis C and we get HIV from, you know, blood contaminants, needle sticks, not from inhalation. And what we're talking about is an inhalation agent. Second is the properties of the virus and where it attaches. So we know it attaches to your the ACE receptor, which is really prominent in the oral cavity, nasopharynx, and breathing it in has a really high infectivity rate. The third thing is that what does the virus do after somebody's infected, and how often is that going to put in other people? And so that R factor of transmission is a big part of the picture too, and that really affects like our PPE supplies and our capacities within our hospital systems. So you can't just look at viruses in general and kind of like lump them together in one category.
Makes sense. Thank you. I'd like to give the opportunity for some of the questions from our audience to get responded to. Dr. McCann, are you in microphone?
Oh yeah, there's a whack of them coming in here, and I think it's going to be tough to answer every one of them. But one question that was indeed asked is there any science that shows that aerosol generating procedures have caused COVID infection transmission? And I think that's kind of been answered by Nick and by Graham. But in my dive into the literature, certainly what I have read is that most of the information regarding aerosol transmission of COVID-2 is based on SARS-CoV-1 and the experience of 2003. And they've been able to show COVID-2 or SARS-CoV-2 virus particles on air intake. They've shown it on doorknobs. They've shown it on toilet seats. But they really haven't made a true connection between the aerosolization of the virus and indeed the transmission of the disease yet, as far as I can see out of the literature. So once again, we have a lot of information out there, not a tremendous amount of clarity, that's giving rise to all kinds of anxiety, both with clinicians and with patients, as we're now seeing people walking around grocery stores wearing N95 masks that are around their neck, people wearing surgical masks and their nose is exposed, and the whole bit. So again, it's going to be a big challenge. And when it comes to PPE, the supply chain just isn't there. If every dental office in North America decides to open up tomorrow, we can't work. Graham?
Questions for me?
Well, you know, if we're going to meet the expectations of our regulators and our politicians, we don't have the supply chain to feed us.
Yeah, I think obviously people have to, just because we can be open doesn't always mean we should be open. You know, economic permission to be open doesn't necessarily equal public health and public safety. And I think, yeah, it has to be a balance. And we might find out that the infectivity rate with aerosol generating procedures, you know, in 2 years with hard data, the infectivity rate is, there's going to be a difference between an N95 and a level 3, but we'll actually have a measurable rate of what that difference is. And that might impact the decisions that we make. But I don't think we have any evidence to suggest now that we're in a position that it's reasonable to back off our protection. I don't know if Sean or Nick or Brian think otherwise.
I tend to agree with you. I think to answer, Kevin, your question about supply chain, I think that I am an optimist. I actually think that the supply chain issue is going to improve. I can tell you what's happening in Toronto is that everyone who had any kind of, who's in the textile industry at all, or the plastics industry or anything, has completely pivoted, producing gowns, producing N95 equivalent masks. I mean, to get these tested and approved will take some time. But I think the supply chain issue is going to be, I hope, is going to be a short-lived problem. I think the big issue is, you know, what part of the aerosol is the problem? For sure, it's, you know, the blast that you might get when you're a foot away from a patient's face. I think that there's, I mean, if you look at the history and the deaths in China and the deaths in Italy, and who was, you know, in the healthcare industry, who was most affected, it's certainly people working in the airway. I think there's got to be a lot more research that's going to look at what I talked about, this kind of these droplet nuclei. You have two completely different studies that have been published within the past month. One that tells you that they're highly infective, and one out of Nebraska recently that tells you that they were not infective at all. The virus that, or the RNA that was found within those droplet nuclei. So I think I agree with Graham that I think we got to be super cautious with our aerosol generating procedures as we're operating. And I think we have to pick and choose our procedures to preserve PPE until that supply chain comes up. But I think it's coming. I
have a quick question. Sorry, go ahead, Kevin, please.
What are people thinking and saying about pre-procedural rinses? My last read from the ADA is that there's no evidence to suggest that things like chlorhexidine, 1%, 3% hydrogen peroxide, any of those make any difference. Any thoughts from anyone else?
I think I've read the same thing.
We don't. So on foam, Yeah. I was just going to say on fomites, chlorhexidine is not effective at killing the virus, but peroxide is. We don't know what that means in the oral cavity, but the problem is that, you know, the studies that you're going to need to do that, you're going to need to do viral culture of aerosols. So we can measure the aerosols. We know that you've got viral particles there, and we would assume that, you know, the very ill patients seem to have higher viral loads, but there's enough heterogeneity in viral loads between mildly ill, asymptomatic patients, symptomatic patients, severely symptomatic patients, that when you want to look at that question about are aerosols infective, that, you know, there's probably going to be a difference between those patients and their symptomatology, and we just don't know yet. Healthcare worker infection rates are incredibly high. At some points in Spain, they were 25%. Currently, it sits at about 9% or so of the infections in Spain are healthcare workers. In China, in the first half, you know, they had to bring in on the thousands of new healthcare workers to replace the healthcare workers that were infected with this. And so they you know, for as much as we know, you know, the reports, anecdotal as they are, that there were no healthcare workers infected, or very, very few, after they changed their PPE protocol when they lost the first wave of healthcare workers to the infections.
If I can ask just one quick question, the four speakers that we have the privilege of listening to today work in fairly large institutions that see a high volume of patients. I'm just wondering if your institutions have any data on the quantity of positive results, the percentage of positive results in testing of asymptomatic patients preoperatively. Do we have data on that?
I know we did a trial in our emergency rooms of asymptomatic individuals, and I think it was, you know, 400 or so patients, asymptomatic patients, in just routine presentations to the emerge, and we didn't have, after they'd cleared screening for COVID, none of them tested positive for COVID. So, but that's going to be, that's very, in the epidemiology on that'll be very community based. So if you're, you know, downtown New York in the heart of the outbreak, the level of community spread is going to be different there than it is, you know, in rural Alberta or some other vicinity.
It's especially so. The problem, disease prevalence directly informs positive predictive value and negative predictive value of any test. And then for diseases which have relatively prevalence, like this one, your positive predictive value is going to be mostly dependent on. You think about it, you know, if we walk around and the CDC right now calculates all their studies, the effectiveness of the studies, they're using a 5% disease prevalence. And so if you think about that, that means 95% of the people that you put in any cohort are not going to have the disease. I could test them for Kool-Aid and then just say they don't have coronavirus, and I'm going to be right 95% of the time. So my negative predictive value test can always be very high. It's that positive value that you want to know, your true positive rate, your false negatives rather, that are really going to be important for us. But they're all highly informed by disease prevalence. And exactly like Graham said, it depends where you are. So we read these serology studies that come out of New York City, or they come out of Hubei, or they come out of Lombardy in Italy, or they come out of Madrid. You can't generalize that to, you know, Alberta. It isn't going to work.
Kevin, any other?
Brian, there was a question. Yeah, there was a question directed about HEPA filtration. And after a HEPA filter, should it be directed outside the building versus inside the building? So are we simply taking dirty air and recirculating it through that HEPA filter again and again and again?
Well, you're not. So with each pass through that filter, the air is getting clean. So yeah, ideally, again, if you could put a HEPA filter into your HVAC system and exhaust that to the outside environment, most ideal. You'll probably increase your ACH. But the way these filters work, and that's why there's still, you know, you have to calculate what your settle time is based on the CFM of your machine, is that actually as the air passes through an efficient machine, each time there's more and more virus picked out of the air and more clean air coming out the other side. So that's that concept of filtering and recirculating. Having said that, you know, seals on machines get a little funky after a while. they get less efficient, you get mixing of air, and that's why this concept of that factor of 1.5, that sort of fudge factor, is really important. So if you get a machine that's just getting you to 12 with the CFM that's rated on, you should probably invest in something that's a little more expensive. But the short answer to the question is you do not have to exhaust to the outside.
My engineer says I'm sitting at 12.3 in one room, 12.1 in another room, and the third room comes in as the underlier at 11.4, I think it is. So I'm pretty happy with that, but again, it'd be nice to see what the regulators say. Any other questions? Unfortunately, I don't think we'll be able to get to all of these, and I'm not sure if we might be able to simply bulk email these to people, or I can sort of pick and choose that the ones that pertain to ventilation, I can sort of funnel them to Brian, the ones on point of care, funnel to Sean, and so on and so forth. We can certainly try to do that, but I just don't think that we'll be able to get to each and every one of the questions that we received. But thank you, everyone, for contributing this evening.
Great. So I'd just like to make a few quick closing remarks. I am very, very appreciative of the fact that the public, if you will, and our colleagues at large have dialed in to listen to this webinar this evening, and that you've taken the time to submit your questions. And as Dr. McCann has mentioned, we will try to, with the help of some of our panelists, we'll try to answer some of those questions to the best of our abilities. I'm sorry that we are running a bit short on time on that. I just want to say that if we could get to the, Stuart, if we could advance to the closing slides, please, the closing slide deck. I'd just like to once again thank our speakers for their very valuable time and for taking the time to prepare these presentations and share their knowledge with us. The Canadian Association of Oral Surgeons is an organization that fundamentally has its premises based on education. And as you've heard, of course, you'll understand that the notion of physical meetings and conferences significantly, potentially compromises that. But a very interesting fact is that in the last 2 seminars, we've mathematically enjoyed a reach that's somewhere of a multiple of 4 to 5 of what the normal attendance is of our annual meeting. So we're actually very happy with the opportunity that this challenge has presented to us. It's presented us an opportunity to reach out to our oral surgeon colleagues across the country, but it's also an opportunity for us to reach out to our dental colleagues and our medical colleagues across the country to understand that we are all confronted with the same challenges. As oral surgeons, much of our activities are vested in hospitals, of course, in some instances, but the vast majority of us are in private practices alongside our dental colleagues and are confronted with the same types of challenges working in very similar facilities. And so I'd like to say that we're in this with you. We're all in this together, so to speak, and use that cliche, if I may. That being said, we look at this as an opportunity to move towards a different platform of sharing information and participating in educational activities. On that note, I'm not sure if the slide deck came up because I wasn't looking at that. Stuart, do you have
Yes, it's up.
the closing slide deck?
Yep. Can you hear me?
Regardless. So I'd like to bring your attention to the fact that...
Yes, Tony, it's up.
It is. Okay.
There we go.
Thank you. So I'd like to bring your attention to the fact that on the subject of future webinars, that in the second slide, our next webinar will take place on Thursday, June the 4th. We would urge you and welcome you to spread the word about this webinar with your colleagues. It's on the subject of acute pain management in adults and children, and it's featuring Drs. Hans Clark and Alan Finley, with none other than Kevin McCann as the webinar moderator. On a parting note, I'd just like to say that we would urge you all to connect with some new social media platforms that we've just launched. One of them is a very nascent or new Facebook page that is a COMS Facebook page. That's we'll call it a public-facing domain that's going to be used to disseminate information on the specialty of oral surgery to the community at large. And we also have a LinkedIn account that's been open, and that's going to be used as a professional-facing page for us to share information and interesting bits of data with each other. We would all urge you, of course, I would urge you selfishly to subscribe to the YouTube channel, where, by the way, this webinar will be recorded and stored for free access. So you're welcome to subscribe to that channel and have access to the other content, as well as the previous webinars which we've hosted. On that note, I'd like to again thank Stuart McCombie from McGill Multimedia for having kindly provided his expertise and brought a tone of professionalism to this event. And I'd also like to thank Alan Holzman from Unconventional Planning and her team for the secretariat and coordination of all the different strings that needed to come together to make this a success. Thank you all very much for listening. We're happy that you've been able to take time to be with us, and we look forward to maybe seeing you at our next webinar on Thursday, June the 4th. Thank you so much.